The next session is Keynote Lecture 7. The chair is Dr. Yasuhito Tanaka. Dr. Tanaka, please.
Okay, hello everyone. So I'd like to invite next keynote speaker, Dr. Mindie Nguyen. So maybe everybody know Mindie because she has several collaboration with us. So firstly, I'd like to introduce Dr. Mindie. So right now she's professor of medicine, division gastroenterology and hepatology, Stanford Medical School. So she has several awards, especially her clinical and research focus has been liver cancer as well as viral hepatitis, recently naming changed MAZRD. Also, she's the chair of Hepatitis B SIG Steering Committee, HCC SIG ASLD right now. Also, practice guideline group, HBV guideline, HBV reactivated guideline also. So she had several multi-center US and international in study, including Japan and China or Taiwan, several Asian countries. Now she has so many collaborators in Japan, maybe several people is coming in this meeting. So today's, okay. So today her topic is strategy for terminating HCV-related HCC. Okay, Mindie, please start.
Thank you. Thank you so much, Dr. Tanaka, for the very kind introduction. And thank you, Dr. Ueno, and the organizers of this meeting for inviting me. I'm very honored to be here. So I'm charged with reviewing the strategies for eliminating HCV-related HCC. So I believe that for us to eliminate HCV-related HCC, we obviously have to first try to eliminate HCV. But as we all know, we have a lot of people who already have HCV. So our other goal is to minimize the burden by HCV-related HCC by optimizing the outcome of people who already have HCC as well. So I would like to first review the general HCV elimination. We obviously need to screen, diagnose, and treat HCV, but how are we doing with it currently? And then what do we do after HCV cure? Who should we continue HCC surveillance after SVR? And the difficult point right now is how to select high-risk patients. And then after HCC diagnosis, so patient already got HCC, can we still do something for them? I believe that yes, we can. HCV treatment, even after HCC occurs, can improve survival. And I hope to show you some more data on this, but how are we doing? Are we treating all of them as we should or not? So first, eliminate HCV, two prongs. One is prevention. We need to eliminate transmission. And second is to treat people who already got infection. And luckily for HCV, as opposed to HBV, we can cure. We don't just suppress the virus, but we actually can cure the patient. So to prevent transmission, we need to promote safe medical procedures, blood products, prevent share needle practice, and treat the source, the injection drug users and incarcerated populations. And I apologize for the typo there. So in a developed country like Japan, safe medical procedures and blood products are not as big of an issue. So the focus would be more in the transmission among the people who are at high risk, like injection drug users, for example. Now, to eliminate existing infection, it sounds easy because we all know that we have DAA for almost 10 years now that has more than 95% cure rates for almost all the populations. But the problem is that are all the people who have HCV infection been screened and diagnosed? That really is a big question, and it varies by regions. the universal screening were cost effective, and we need to link infected people to care, because if they are diagnosed but not treated, not linked to care, then it doesn't really help. And we need to treat the patients. Now, do we just treat HCV simply to cure HCV, to clear so that now the person is free of HCV and to just reduce HCC risk? Yes, that is our first goal, but emerging data show us that we can do more than just that. So data have come from all over the world, and a lot of it come from Japan, have shown clear benefits of treatment with DIA, and we don't need to really go over that. But I want to show some newer data to show that it's beyond liver complications, the benefits of HCV treatment. So the earlier data come from the French cohort, published in 2019 here, from about 10,000 patients from 32 expert liver centers in France. And this clearly among the earlier data to show us that we can reduce HCC incidence and improve the overall mortality. Newer data that we were able to show from the US, and these patients come from all over the US and are community-based. So it's not just restricted to university, tertiary care liver centers. And this includes about 250,000 US people. And we performed this work with Dr. Ogawa from Kyushu, one of our former visiting scholars. And we showed that not only the liver complication, HCC and hepatic decompensation, but non-liver incidents of diabetes, CKD, kidney disease, heart disease, non-liver cancer are substantially reduced. And the overall mortality was reduced by more than half. So it's really a remarkable achievement for this treatment. But how are we doing overall? So we have a very good, effective medication that is well known to have benefits. But according to data from the WHO as of 2019 here, only 26% of the viremic HCV burden of about 58 million people worldwide here have been diagnosed. So 3/4 have not been diagnosed, and only about 16% have been treated. In Asia Pacific, the data is similar, just a little bit worse. Only 21% have been diagnosed and only 11%. So 9 out of 10 viremic HCV people in Asia Pacific have not been treated yet. The data would be probably much better for Japan, but the government reimbursement and coverage, health coverage for people with viral hepatitis in Japan is probably among the best in the world and probably the envy of the world. But the reality of the data for Asia Pacific overall is quite bleak, as you could see here, as well as globally. How about the impact of COVID pandemic? It actually makes things even worse, as many data are emerging and showing us here. So this is a result of a questionnaire survey to clinicians toward the end of 2022. And this is an effort led by Dr. Junto Tanaka from Hiroshima. So there are a lot of regional variation, as you could see here. The blue are the responses of clinicians who did not feel that the pandemic have impacted their HCC screening and treatment efforts. So you can see that in Bangladesh, the blue is 0. So everyone felt that they were impacted. Global is about 6.8% not impacted, the rest impacted, and 28% from Japan. So as I alluded to earlier, the care cascade may be less impacted and more favorable in a place with very good government and public health policy in place. But overall, even in Japan, the majority, more than 70% of clinicians here felt that their treatment and screening a patient with Hep C were impacted. In the US, we have data that is not just based on survey, but real data of patients with HCV diagnosis and treatment. You could see a dramatic drop here during the pandemic in 2020 and 21 here. Number of people diagnosis as well as treated, you could see that it was in the thousands before the pandemic, dropped down to less than 500 diagnosed during the year of the pandemic in this same cohort. And this is from the whole nationwide. This database included more than 60 million US people. But one thing to note is that you could see that the trend already decreased even before the pandemic. And I believe that this is probably due to the wearing off effect of the warehousing, because before DAA come out, we all kind of warehouse our patient and then bring them in and treat them. So there's a lot of enthusiasm in diagnosing and treatment of hepatitis C right after the DAA becoming available. And then what we are left with several years after DAA came out was just a population that were difficult to find, difficult to reach, to diagnose, and to treat. And then this is actually one of the most concerning data. This data come from the whole of US CDC data from 50 states, 50 out of 52 states in the US. So in this we can see, you see the solid line there, that shows the actual trends of HCV-related death in the US. And in the shaded area, those are the pandemic era. So you could see that according to the projection, the number of deaths should continue to go down, but the observed number during pandemic was much higher for both overall as well as liver-related death due to the pandemic. And the table in the bottom showed that the downward trend of negative 7.8 per year in the annual percentage change of HCV death in the US were plummeted to only 2.8. So you could see that clearly the pandemic is not just based on survey as we have for the global data, but in the US we have objective data to show that clearly the HCV effort were really impacted. Now switching to after HCV cure, so we need to clearly have a lot of work to do to tackle the HCV elimination efforts, but what about the people that we are lucky enough to get diagnosed and to get treated and to get cured? Are they all home free? Not really. There is residual HCC risk that we all know. So early detection is essential for early diagnosis and improved survival for these people here. But obviously, not everybody needs to undergo HCC surveillance after HCV cure, and it would not be possible anyway. So who should? So this is the crux of the problems here. So this data come from George Oanu in Washington, Seattle. And this data show both interferon and DAA data. So DAA follow-up not very long with this, but you can see up to 10 years later after SVR from interferon, the risk of HCC persisted to more than 2% per year. So that is clearly significant. And you can see that even though the risk for people less than 3.25, FIB4, is lower than the other group, they are not that much different if you look at the 10-year mark there. And remember that the cutoff of 3.25 is not just for cirrhosis, but it also includes people with F3. So I just want to share a very brief example that many of you probably have also experienced here. This is a patient who got HCV cure from another physician outside of Stanford and got a fibroscan that showed no significant fibrosis, but somehow the patient get referred to me. So before I went into the room, I thought, why is this patient here? Why is this doctor sending the patient? But as soon as I saw the patient, I understood why the doctor sent. The patient had lots of spider angiomata and deep pulmonary edema, signs suggesting cirrhosis, even though the non-invasive test suggested otherwise. So I repeated the blood test, and again, the FibroSure test is negative, but the FibroScan repeated within 30 days from that show a KP of 8.8. So not quite cirrhosis, but clearly some fibrosis there. So in this patient, putting everything together, I suspected that she has at least advanced fibrosis and more likely cirrhosis, and I offer HCC surveillance for her. So this data is based on mainly data before HCV cure, and we know that after HCV cure, the test is not as accurate. So even in this better performance here, we can see that based on meta-analysis of 172 studies for HCV here, the accuracy rate is only in the 70% range for significant fibrosis and only 80% range for F4. So this suggests that even in the best scenario, we may be wrong 20% of the time. So it's important to kind of put all the clinical pictures together. So currently, the AASLD only recommends F4 for HCC surveillance, ESO F3 and 4. My practice is that I would offer it to patients with F3 as well. And as you could see, after SVR here, the virus is gone, but the drivers of cancer would be the fibrosis as well as other HCV-related genetic and epigenetic changes that drive the risk. So we have the high risk and low risk, and many efforts have been, many risk scores have been developed to try to help predict these patients. And another thing to also remember is that even in people with recognized cirrhosis, adherence to HCC surveillance is poor. So we need to improve our efforts in HCC surveillance for people with known cirrhosis, as well as our effort to accurately diagnose advanced fibrosis and cirrhosis, because it can be rather challenging in some cases. And then another case I want to share with you is other factors outside of HCV, such as metabolic fatty liver disease. So in this case, a patient had compensated liver disease, got cured, but over time developed decompensation, and that is unlikely to be done due to HCV anymore because it's several years after HCV cure, but this patient developed fatty liver disease. So this is another thing to kind of put in together. We are done with HCV, but there are other things besides HCV that can drive the problem for our patients. So as I alluded to earlier, many efforts, many risk scores, none of them have really sort of like universally accepted yet. But the general theme is that fibrosis, cirrhosis, older age, certain ethnicity, genotype, liver function. But one of the biggest besides fibrosis and cirrhosis is fatty liver. So in one study, the adjusted hazard ratio to predict HCC in people with fatty liver is 7.5, so 7.5 times higher. So it's a big factor in people with HCV. And as you know, that HCV by itself is associated with hepatic steatosis besides the metabolic factor. Now, what about after HCC diagnosis? So after HCC diagnosis, we can still treat and help these people to minimize the mortality and the morbidity burden. And data have shown, as in this study that I was fortunate to be able to do with many colleagues in many countries, include several from Japan, SVR with DAA can improve survival by a lot. The incremental benefit, as you could see here, median survival from 26 to 44 months, so quite a bit of incremental benefits in people with HCV cure. And interestingly, you could see that 63% improvement in 5-year overall survival and 66% in liver-related. So most of the improvement, at least in the people who already got HCC here, is probably derived from the benefits from the liver. And another thing to note that if you look at the data carefully in the systemic HCC treatment data recently, like the one with carbo and atezo here, the statistical significance in terms of survival benefits were only significant in people with viral disease in subgroup analysis. So overall, it was statistically significant. But in subgroup analysis of viral and non-viral, it was only significant in people with viral disease and not in people with non-viral disease. And I suspect some of this has to do with the fact that the viral HCC patient, at least some of them, were treated with also antiviral. But are all of them treated? So data suggests in the US suggests that only about half of them were treated. But in this data that come from the US as well as Japan, Korea, Taiwan, and Singapore, and all of these are from highly specialized liver centers. So we could see that after 2015 with DAA, then 74% of the people who had HCV-related HCC that underwent resection. So this is like maybe the luckier patients, and maybe already self-selected, right? That they probably get surveillance more carefully so that they get diagnosed early and get resected. And even in this highly selected population, in highly specialized center, only about 74% of them receive DAA. And the data that we found here, you could see quite a large survival, overall survival benefits at 10 years among treated, the red line on top, and the untreated populations. And interestingly, the difference is a lot smaller in recurrence-free survival. So I suspect that in this cohort, the benefit, a lot of it is driven by the non-cancer, maybe non-liver benefits. Maybe they have reduced in diabetes and other cancer and CVD, etc., to give us such a large benefits in overall survival. So there are much to do in many different scenarios, as you could see here. So the strategies to eliminate HCV-related HCC should include HCV infection elimination, which includes prevention as well as curing the people who already got infected, and minimizing the burden of HCC from people with prior existing HCV infection. HCV elimination progress is lagging in most places in the world and significantly got hampered by the COVID pandemic. So whichever efforts that we were trying to do previously or are doing, there needs to be a lot more, both at the individual as well as system national level. Patients with known and suspected cirrhosis or advanced fibrosis should be considered for long-term HCC surveillance, as data show that even 10 years later, HCC residual risk continues. And DAA treatment has been shown to improve survival significantly and should be considered for HCV-related HCC. With that, I would like to end, and thank you so much for your attention.
Okay, thank you very much for Mindie. So wonderful talk for especially HCV eradication by DAA therapy. Also after HCV eradication, strategy for HCC screening, also treatment. So do you have any question for audience? Any question for Mindie's talk? So Omata Sensei, please.
Nice talk, Omata. Hello. How the WHO claims 2030 the total elimination of HCV. If it's a case of rabies, for example, it's totally fatal. So you know that's maybe disappearing. But in case of the silent killer like HCV, how do you are able to claim it's totally eliminated? How do you do?
Yeah. So, you know, as you know, for both Hep B and Hep C, they are silent killers. And for HCV, the problem, so a study up to 2017 in the US estimated that 50% are still not diagnosed based on epidemiology data. And I have seen people trying to focus on the incarcerated and injection drug users, but it's really hard. Like, I rarely see any new HCV patients at Stanford anymore, because I think the ones that are easier to reach and diagnose, we already diagnose them and treat them. So now I think that we all have to be more creative and try to reach the populations that are very difficult to reach. People who don't want to know, who don't want to be diagnosed or to get treatment. So HCV elimination 2030, which is not very far from now, only 7 years from now, I don't think that's going to be anywhere near elimination. Even 2040, I don't think so. So even though, so this is a good example and lesson for us in the medical field, that we can have a good treatment and a good test, but there's a lot of work in terms of linkage to care and public health work that we need to engage maybe non-medical people from the public health sectors and patient and other stakeholders.
You know, I have a strategy to do that in the islands, 4 islands surrounded by the oceans, but you have more difficulty. In other words, you have a new drug users, new infected ones. We don't have practically. So maybe Japan can do things like to claim we eliminated the virus. We have some strategy.
Yeah.
Okay, Tateishi-sensei, please.
Tateishi from University of Tokyo. Thank you for your very informative lecture. You have shown that the survival curves affected by the DA treatment after resection, and there is a wide difference between the recurrence-free survival and the overall survival. You stated that the difference is caused by the non-liver disease caused by HCV, but I think the effect of on the liver cirrhosis development or liver failure is more prominent in patients with who are treated with DAA, because that, as you shown, that to suppress the recurrence of DAs might be quite small, but we observed the very improved liver function after DA treatment, even in the cirrhosis. What do you think about that?
Yeah, thank you for bringing that up. I totally agree with you. I think that the large incremental benefits in the overall survival, a lot of it must have to do something with the liver function, as we show in an earlier study that the overall and liver related deaths are pretty similar. So from my experience also, they may have recurrent cancer, but because the liver function is good, we can continue to send them back for more tests or repeat resection. So a lot of it is probably that, and some of it may be, because they live long enough, like 10 years, so they could reap the benefits of non-liver outcome, like, less risk of diabetes and heart disease. In our earlier study that we saw similar impact by liver and overall survival. That was an earlier study, and our follow-up was only 4 years. But the more recent study that we showed, there was like 10 years. So maybe early on, almost all the benefits may be on liver from recurrence and liver function. With time, then maybe there will be more of the non-liver. It's just my speculation with that. We cannot really prove it in this same study, but I totally agree with you.
Thank you very much.
Okay, thank you very much. I have a simple question, Mindie. So recently, HCV new infection is still increasing in the States in drug users. So it's difficult. I think it's difficult to eradicate HCV until 2030 in the States. So my question is, how do you prevent HCV new infection in the States, or you have strategy for HCV elimination in the States?
Yeah. So historically, people were not so enthusiastic about treating people who were actively using drugs, because the argument is that you treat the patient and they will reinfect themselves. But in the last few years, we have moved away from that and recommend treating them, because even if we may have to treat them again, because while they are infected, they will infect other people, especially in the incarcerated or institutionalized populations. So I think that is improving. The problem with that is that a lot of these patients, people who use injection drugs, they come from very isolated. You may have heard about the Appalachian in the US. They call it the Rust Belt of America. So these are very rural people, live in the mountains. So these are very poor communities where people are prone to these problems. And they have little access to medical care, and the public health facilities also limited. So there's a lot of challenges in the US with these special populations. And in the US, we have a much more heterogeneous populations. We have people of all colors. doctors and immigrants from everywhere, and the access, to care is very different to many of these communities. So it's quite a different environment than like in Japan.
Okay, thank you very much. So now I'd like to close this session, keynote session. Okay, thank you very much, Mindie. Thank you.
Thank you.
Thank you very much, Dr. Mindie and Dr. Tanaka.